Okay, so good morning, everyone. So we had a new grand rounds today, and we had a very special speaker today, is Dr. Eva Feldman. She's the Russell and Dijon Professor of Neurology at the University of Michigan. She's a renowned neurologist and neuroscientist. She has devoted her career to understanding neurological disorders and developing new treatments. Dr. Feldman has a medical and a doctoral degree at the University of Michigan, and she completed her neurology training at Johns Hopkins Hospital. So Dr. Feldman has been continuously funded by the NIH for over 30 years, and she has been the pioneer of neurological studies, many in neurological disorders, including ALS. She has been the principal investigator for the first two FDA-approved stem cells transplant clinical trials for ALS. And she has been also working in another very exciting topic that is the Expososome on the ALS. Michigan Medicine, she directs a research program of 25 scientists and is the co-director of the neuromuscular division. Dr. Feldman has over 500 publications. Also, it's remarkable that Dr. Feldman, she was the past president of the American Neurological Association from 2011 to 2013, and she was the third woman to hold this position in 130 years. She had a member of the Association of American Physicians, a fellow of the American Association on Advancement of Science, and currently chairs the Neurology and Psychiatry section of the National Academy of Science. She has received a number of awards for her clinical service and research, including the NIH Director Transformative Award in 2021 for her work on ALS and Expososome. So I'm very pleased what Dr. Feldman said, accepting our invitation, very happy, and just having you here is a fortune.
Thank you so much, Sergio, for that kind invitation. It's been wonderful working with you. As I indicated, you've been very kind as we've had to make some date changes. I'd also like to thank your department for inviting me. I'm very pleased to be here. You've heard my name. Here are my funding disclosures. I have no industry disclosures. Today, I'm going to talk about the new age of ALS treatment and prevention. So, here is a very famous video clip of Lou Gehrig, the very famous Yankee baseball player, that a myotrophic lateral sclerosis is frequently referred to, i.e. Lou Gehrig's disease. He himself knew that he wasn't playing well, and you can see the frustration actually in his mannerisms and in his face. And this is his very last time at bat. He voluntarily took himself out of the game. He went to Mayo Clinic, where he was diagnosed with the disease that carries his name by two University of Michigan trained neurologists. So what is Lou Gehrig's disease, or amyotrophic lateral sclerosis? Well, it's a progressive lethal neurodegenerative disease of motor neurons. But importantly, it's just not motor neurons, it's complete motor network connectivity of the brain. And so we now know that ALS can broadly affect the entire brain connectome. There are multiple disease types of the ALS. Patients can present with bulbar or just speaking difficulties, limb onset where limbs are weak, yet speaking and breathing remain intact. There's a flail arm where just an arm is affected, or a leg, and there's also respiratory onset. Importantly, we now know that 50% of patients experience cognitive decline, and that's somewhat of a new understanding of the disease in the last 10 years. Here's a very interesting picture. These are Lou Gehrig's arms from a picture taken from the Mayo Archives. Approximately 5,000 cases are diagnosed annually in the United States, and from diagnosis to death is 2 to 4 years. This is expected to increase by 70% by 2040, in part due to our aging population, but also in part, as you will hear today, we believe that the incidence and prevalence of ALS is generally increasing, irregardless of age. Sporadic ALS, indicating we're unsure of exactly the heritability involved, is about 85% of cases, while 15% of cases carry a clear mutation. There are only two mostly ineffective FDA-approved drugs. Now, here's an example of a slice of a brain, and here we have what are known as the upper motor neurons. And these upper motor neurons then send down connections to what we refer to as lower motor neurons or motor neurons. The cortical spinal tract and the upper motor neurons are frequently affected in ALS, giving the upper motor neuron or spasticity component and hyperreflexia component of this disorder, while the lower motor neurons are also affected. And when these lower motor neurons lose their innervation to muscles, that of course results in the muscle weakness that one sees and the fasciculations and atrophy. So there have been many research advances in ALS, and let's discuss them broadly. First, our understanding of the genetic architecture of ALS. There are now 40 known genetic mutations for ALS. I've listed here the four most common mutations, and the C9orf72 mutation, which has just been discovered in the last 10 years, likely accounts for about 70% of the known genetic presentations that we see in clinic. This has led to a very robust effort to increase our gene therapy toolbox, which I'll discuss today. We also now have clearer insight into the pathophysiology of ALS, in part because we're trying to understand the pathophysiology of these new known genetic mutations. In parallel, we know that ALS has a clear inflammatory component, which I will discuss today. New clinical progression tools are being formed and developed. I will not discuss those today. And finally, we will discuss expososome science, our understanding of the intersection of ALS with the environment. Now, with these research developments, also come then the development of multiple new ALS candidate therapeutics. As I've mentioned, we now have a much better gene therapy toolbox, and today I'll discuss briefly what is contained in this toolbox. Secondly, because of our increased understanding of pathophysiology, we have small molecules and peptide candidates and antibody candidates, both of which we will discuss today. And we will also briefly discuss cellular therapies. So that's going to be the focus of the talk. Let's not as much the basics of the pathophysiology, but more where the pathophysiology has led us today in developing new treatments. So let's begin with just basically talking about moving DNA to RNA and to protein. I'm just, excuse me for a moment while I move this very annoying hide video panel. I think hopefully I'm not going to hide my entire screen. Oh, I did. Wait a minute. Excuse me. I'm trying to hide. Here we go. Hide floating meeting controls. Let's see if this does it. Ha ha. Okay, thank you. I had my screen, covered by that Zoom piece on the bottom. So now let's get back to work. DNA to RNA to protein. So as you know, DNA is transcribed in the nucleus to RNA, and then RNA is transported to the cytoplasm. This RNA is then known as messenger RNA. The messenger RNA is then translated in the ribosome using transfer RNA to provide amino acids as proteins are then translated. So very quick refresher. Okay. So importantly, let's also recall that DNA are total genes. And then from total genes, we have the pre-mRNA, which is seen in the nucleus. And then the introns are removed from the pre-mRNA to make mature messenger RNA, which we see in the cytoplasm, which is then translated, as we said, into a protein. Now, what are antisense oligonucleotides? Well, these are simply synthetic nucleic acids that hybridize to specific target RNA sequences and result in RNA degradation and loss of protein translation. So here we see an ASO that can then enter the cell, and it targets the mature messenger RNA, causing its degradation. Alternatively, the ASO can also enter the nucleus and target the pre-mRNA or the more fully mature RNA, again causing mRNA degradation. So there are several antisense candidates currently in clinical trial for ALS. The most common currently clinical trial for an antisense oligonucleotide is actually focused against the SOD1 gene, which I'll discuss shortly. But in either case, we can then have a target of the ASO in the nucleus to the pre-mRNA, or an ASO can target the mRNA in the cytoplasm. Regardless of where it targets, the end result is a lack of protein production. So the biggest ASO trial so far that has occurred in neurology is for patients with familial SOD1, which is superoxide dismutase 1, which is the second most common inherited gene for ALS. And this ASO is delivered intrathecally to patients with active disease in the phase 1 and phase 2 trials. And interestingly, these trials clearly showed safety, and there was reduced CSF levels of SOD1 protein and reduced neurofilament levels, which is a biomarker of disease severity. So this trial went on to a very large, for an inherited ALS form, a large phase 3 trial. Unfortunately, the trial did not meet the disease endpoint, which was a measure of what's known as the ALS Functional Rating Scale revised. So it's a measure of function. Although interestingly, both the SOD1 protein and neurofilaments were again decreased. This was a very disappointing result. It was announced at the ANA meeting last October. So what is currently planned is a new 2-year trial with monthly delivery in pre-symptomatic SOD1 patients. So patients who carry the mutation but have yet developed symptoms of ALS, with the idea being maybe early treatment will be effective. There are other gene therapy candidates for ALS using the same general idea. So here, AAV, adeno-associated virus, is being used to deliver a microRNA, which then is incorporated into the genome. This microRNA is then produced, and this microRNA has been developed to target mature messenger RNA, causing its degradation. This approach is an investigational new drug application also for SOD1. Now, the advantage of this approach versus the ASO, which I just explained to you, is that the ASO needs to be given intrathecally monthly. Well, this is only a one-time application. Now, let's turn from gene therapy to talk about small molecules and peptide candidates. In order to discuss that, we certainly are going to talk about the pathophysiology of ALS in any detail, but here are the multiple areas that can be targeted by these small proteins and molecules that represent the pathway targets for ALS therapeutics. In particular, people have been very interested in impaired RNA splicing and metabolism, mitochondrial dysfunction, glutamate toxicity, and reactive oxygen species. But many of the current drugs target multiple of these pathways, and then many target only one single pathway. The small molecule and peptide candidates for ALS that are currently in a phase 3 trial, actively enrolling, are the following. There's a troponin activator, muscle strength, a troponin activator, which is to improve muscle strength. I never even try to say the name here, and it's in a phase 3 trial. There's Amylex 0035, and it is actually 2 drugs that have been formed into one. One drug targets ER stress. The other is an antioxidant that is to improve mitochondrial function. There is a tyrosine kinase inhibitor, which is an anti-inflammatory drug in a phase 3 trial. And then there are multiple other candidates in phase 1 and phase 2 trials. Again, these are either small peptides or small molecules. Now, in the field, many people question whether one drug or even a combination of 2 drugs will be adequate to stop the progression of the disease in sporadic ALS. But certainly that is the current goal of many of these trials. Finally, in terms of a broad introduction, there's also cell therapy candidates for ALS. Cell therapy has been a topic of interest in ALS for almost 20 years. The sources of cell therapy can be mesenchymal stem cells that are derived from bone marrow. You can have peripheral blood cells where you derive stem cells, adipose-derived mesenchymal stem cells, or neural progenitor cells. These are usually derived from spontaneous abortions where spinal cord tissue or cortical tissue of a fetus 4 to 6 weeks old is harvested and neural progenitor cell lines are created. Here I'll show you a movie from our own phase 2 clinical trial where we injected neural progenitor cells into the spinal cord. So let's hope this plays. Oh, it's not playing, that's unfortunate. Let me just try one more thing to see if I can get it to play. Well, so let me just explain to you then. So this is a human spinal cord. So in this particular phase, this was from the phase 2 clinical trial, we directly injected neural progenitor cells into the human spinal cord. We actually successfully were able to do 20 injections on each side of the cord. Of course, it was difficult, and this was not a minor surgery. The next slide, oh, bingo. Haha, well, I'm glad that worked. I just thought you would be interested in seeing this. These particular phase 1 and phase 2 FDA approved trials did get a lot of, garnered a great deal of interest. So as you can see then, the first thing we had to do was expose the spinal cord prior to being able to do intraspinal injections. And here you're seeing an intraspinal injection. We had to develop a special injector and delivery method so that we were able to safely inject into the cord while the cord itself was moving. And so here you're now looking at an injection that is occurring in the spinal cord of these neural progenitor cells. This particular trial showed safety. There was a suggestion of efficacy, but a phase 3 trial has not occurred, in part due to finances. So now let's move from those 3 types of therapeutics to antibody candidates, and particularly with an emphasis on the immune system. To discuss the immune system in ALS, I believe is very important because many of the current drugs are also in phase 2 trials are focused on the immune system, the majority actually. So why? Well, remember I showed you this diagram before of these multiple pathways that cause ALS, but they have one thing in common. They all converge on neural inflammation. So the idea that you can target neural inflammation has become a prevailing one in the ALS field. However, we've done past trials against the immune system and they failed. And I would say why? Well, they didn't factor in different cell types. And I'm going to show you today that different cell types are affected in the immune system in ALS. They didn't factor in cell characteristics because immune cells are not all pro-inflammatory, some are anti-inflammatory. And we have now very interestingly discovered that there are clear sex-dependent differences in immunity, which I'll share with you today. So let me do a little refresher on immunity. There is the adaptive immune system and there is the innate immune system. Today, we're going to be talking about specific members of each of these systems. We're going to be talking about T cells, natural killer cells, which actually span both adaptive and innate immunity, and neutrophils. So what is the adaptive immune system? So this is the system that recognizes cells as belonging in the environment as self, or not belonging, foreign to the environment, non-self. So, and this particular part of the immune system recognizes whether this cell is self or non-self based on surface molecules. So in short, immune cells recognize and bind to surface molecules from non-self cells and destroy them. This particularly is the role of CD4 and CD8 T cells. And here you see a photomicrograph of an actual CD4 T cell. Now, in contrast, the innate immune system is a very non-specific attack of non-self-invading material and debris. So bacteria, viruses, that type of invasion into our bloodstream or however it enters is what triggers the innate immune system. Its main players, again, are macrophages, and neutrophils. And here's a nice scanning electron micrograph of a red blood cell with where we see both macrophages along with T cells, neutrophils, along with T cells. So interestingly, it's important to note that the role of the immune system changes over time in ALS. And that's likely, again, why many of the trials have failed. So early on, it appears that the immune system has an anti-inflammatory stage or a protective stage. And then as the disease progresses, the immune system enters a pro-inflammatory stage. And here we're looking at data that comes from both our laboratory and that of Stan et al.'s, where different markers of inflammation were examined in mouse models over time that confirmed this idea of early inflammatory versus later pro-inflammatory. We now have data in patients that also supports this, which I'll share with you. But in brief, there's an early protective anti-inflammatory stage in ALS, which is particularly marked by high levels of CD4 T cells. As the disease progresses, there's a later pro-inflammatory stage, which is particularly marked actually by activated neutrophils along with activated NK cells. And we don't understand why the switch occurs, but temporally the switch does appear to occur as disease progresses. So here are data from our own work where we looked at a total immune cell types showing that they differ in ALS blood between healthy controls and ALS patients that are sex and age matched. So in later stages of disease, we looked at CD4 T cells, and what we saw was a clear decrease in CD4 T cells, the total number, and those are the good anti-inflammatory cells, recall, in ALS patients in two separate cohorts. In parallel, when we looked at neutrophils with disease progression, we found there was a clear increase in one cohort and a trend of increased neutrophils in a second cohort. What we then did was look at both neutrophils and CD4 T cells over time as the disease progressed. Now recall, I've mentioned the ALS functional rating scale, the ALS-FRS. What's important to note here is the lower the score, the more severe the disease. So what you can see is as the score gets lower here with neutrophils, the neutrophils statistically increase. But as the score gets lower, i.e. as the disease progresses, you'll see that the CD4 T cells decrease. So this is another piece of data where humans replicate the mouse data. We've also looked at the impact of blood neutrophils on ALS progression. And I find these data particularly interesting because it shows the sex dependence of this disease. So we took our cases, this is now another separate cohort. We took all of our ALS cases and we divided the number of neutrophils at onset of diagnosis into tertiles. So either a low neutrophil amount, a medium, or a high neutrophil amount. And then we looked at their survival probability. And as you can see at time of diagnosis, the lower your neutrophil count, the greater your survival, by almost twofold, okay, if compared to the higher neutrophil count, which had a 1-year average survival versus a 2-year average survival with a low neutrophil count. We then divided this cohort into male and female, and that I think gave us our most astounding result. And that as you see in females with low neutrophils at diagnosis onset, they have clearly the longest survival. Those are highly statistically significant difference here. So the impact of blood neutrophils on ALS progression occurs and is sex dependent. We also show the neutrophils infiltrate the spinal cord. And these are data that we've published where we did flow on fresh autopsy tissues, looking at the looking at the spinal cord types of immune cells. And we see an increase in neutrophils in both the cervical cord and the thoracic cord. Now, I mentioned another type of cell, a natural killer cell. These are very interesting cells. They police the environment. And what they do is produce cytokines to perforate and kill infected cells or cancer cells. So again, this is a type of cell that when it sees a cell in our body and that doesn't belong, this immune cell, this natural killer cell, goes in and attacks it. And it uses a perforating or receptor mechanism, which I'll show you. But I really like this picture where it shows the NK cell, the natural killer cell, is in pink and it's attacking a cancer cell. And how does it do this attack? Well, the NK cell notices or is able to sense that the cancer cell has a foreign outside on its membrane antigen. It causes the NK cell to release granzyme B or porphyrin, and these molecules go in and they're able to dissolve the cancer cell. In contrast, when an NK cell sees a normal cell, that's self, it then does not attack that cell. So why am I so interested in NK cells? Because I am. And that's because human ALS motor neurons lack MHC1, the major histocompatibility antigens. So they actually become targets for NK cells. Let me show you these data. So here's a human spinal cord. And here's a normal healthy cell, and what we have from a normal healthy patient, and what has been labeled are the MHC antigens in motor neurons. And you see that the motor neurons express, as you would expect, a normal complement of MHC antigens. In contrast, in sporadic ALS, there's no expression of these MHC antigens. These are from humans. And again, now these are from humans. From normal controls, patients with familial ALS, these are actually SOD1 patients, and then sporadic ALS. And looking at those patients who have the HLA haplotype, 100% in the normal controls, while in ALS, whether it's familial or sporadic, they lose the major histocompatibility antigens, and there is no HLA haplotype antigens present on their surface. So, of course, the NK cells can recognize them and believe that they are non-self and attack them. And what we have seen clearly is there's an increase in NK cells in ALS cases and in mouse models of ALS in both the plasma and importantly also in the spinal cord. And here I'm showing you data that we've published from the plasma looking at, and that shows an increase in NK cell number. But again, we've also seen it in the spinal cord of mouse and man. We've also shown that blocking NK cell activity with either a monoclonal antibody or a drug inhibitor increases ALS survival in mice. In summary, immune cell trafficking to the central nervous system. It's an exciting topic. I have shown you strong data that in the periphery, we clearly have a difference in immune cell types. I've shown you CD4 T cells, neutrophils, and NK cells. I've also shown you data and discussed data that shows that these cell types appear to pass the blood-brain barrier and actually enter the central nervous system, where we believe they can be pathogenic and promote further disease and disease progression. Now, immune system summary, and then also I want to talk about 3 immune cell types that I've mentioned now multiple times that can be targeted for therapeutic consideration. I've shown you immune cell populations differ in blood. The CD4 T cells, which I mentioned to you, are positive. They're good for the disease. Counts are lower in ALS. I've shown you that disease and correlate inversely with progression. So Dr. Stan Appel is currently doing a trial where a subset of these CD4 T cells, known as T regulatory cells, are being infused in ALS patients. This is a phase 2 clinical trial. Neutrophil counts are higher in ALS and correlate proportionally with disease progression, and survival is sex dependent. NK cell counts are activated and are higher in ALS and are proportionately can be decreased by giving a drug, tofacitinib, which is an NK cell suppressor. I've not discussed that data with you. The University of Michigan does hold a patent for that particular drug in its use in ALS that is still not in clinical trial. And we really think that if immune therapeutics are used, we need to consider specific cell populations and sex differences. So in terms of testing candidate ALS therapeutics, previously we did serial trials where serial trials are hard. There's a placebo arm, a control arm for every trial. If it doesn't work, we move to the next, etc. There's now a platform, what are known as platform trials that are occurring in ALS. And this is a very large undertaking that's being led by Massachusetts General. And simply, there are multiple therapeutic arms, drug trial arms, and only one control arm, allowing multiple drugs to be tested simultaneously. Currently, there are 64 ALS centers involved in the Healy platform trial. We are one. And one of the reasons I spent some time on the immune system, as the first 3 drugs tested in the platform trial were all focused on the immune system: complement, microglial inhibitor, and a macrophage inhibitor. So it's an exciting time to be an ALS physician. There are multiple clinical trials, and we're so hopeful that one will truly hit. But I've always wondered in my entire career if should our hunt for ALS treatments also lead us on a hunt for ALS prevention. I want to show you data that I hope convinces you that yes, it should. And this all started with a clinical case. And I was a young ALS physician. This happened about 20 years ago. And I saw a couple in my clinic. And I looked, and neither of them looked in very good shape. So I at first was trying to figure out who was the patient and who was the spouse, only to find out they had made a double appointment because they both found that they weren't doing well. A married couple, and they both had ALS. And I had not seen that before. I have now subsequently seen that in my career, although not simultaneously before. But what occurred to me when they presented to me was their location in the state of Michigan, because I knew that I also took care of 3 other patients living in that very same small town. And that led me to my interest in understanding what the expososome is, and is there an interaction of the environment with the disease. So for all the younger physicians on this particular Grand Round Zoom, if you listen carefully from your patients, you learn so much, and I think it does also stimulate your scientific interest in scientific inquiry. So the expososome in ALS is what I'd like to end my talk with. Why am I so interested in the expososome, which in its simplest definition, I should go back a slide, is everything you are exposed to throughout life. And I'll show you and discuss this briefly shortly. But why? Not only this case, but the fact that if you look at the data, the ALS prevalence is highest in the Midwest. And I'm speaking to you from Ann Arbor, Michigan. Indeed, we believe that Michigan likely has the highest prevalence of any state in the United States based on some of our newer data. But if you look at the prevalence of ALS, and this comes from very nice data from the CDC, these are the cases per 100,000. Look at the difference between, for example, the Midwest and the West. And we actually have been very interested in this because we see so many cases and such a high prevalence of ALS in Michigan. Let me now share with you a very interesting map. So maps. Here's the state of Michigan, our main state that we call the Lower Peninsula and what we call the Upper Peninsula of Michigan. This is a highly populated state, particularly here. This is where the city of Detroit is, and Ann Arbor is about 40 miles west of Detroit. If you look at the age-adjusted death rates for motor neuron disease, and that's essentially defined as ALS in Michigan, from 1999 to 2010, these age-adjusted rates are then indicated in red. And you can see here, the highest rates are in red, 3.6 to 4. And notice I've circled the counties in Michigan that have the highest rates. In parallel, I'd like to now show you maps of our state, which look at the location of the major emissions of toxic substances in Michigan facilities from the TRI inventory. So essentially, these are the national priority list for the dirtiest Superfund sites shown that need to be cleaned. The dirtiest Superfund site, one of the dirtiest, is in the Upper Peninsula of Michigan. This area is very, very sparsely populated, yet it has the highest age-adjusted death rates for motor neuron disease. I show you 2 other areas of Michigan which are very sparsely populated, yet have the highest age-adjusted rate and the highest and most unclean Superfund sites, the dirtiest. So that really led us and has sparked our interest, coupled with the fact that now I told you about my early story, but now we have multiple individuals that come to us as self-identified clusters in Michigan. And here I'll show you red circles that indicate the homes of 3 friends that later developed ALS around the same time. And they self-identified and came to me in 2018. This is not atypical for our clinic now. This is much more typical. So our interest is extremely high on understanding the expososome and what I'll call the ALS gene time environment hypothesis. The expososome is your cumulative lifetime exposure to essentially everything: metals, brain trauma, water, air traffic and pollution, pesticides, agricultural chemicals. This hypothesis is as follows. When you're healthy, you have a natural genetic load which may predispose you to certain disorders may make you more susceptible to not be able, for example, to handle certain toxicants and pollutants. Cell damage occurs over time with natural aging, superimposed by environmental exposures. And then this whole process can be a self-perpetuating process leading to disease. So in order to test this idea, we at the University of Michigan have been looking at 3 groups of chemicals in the whole blood of our ALS cohorts. We've been examining chlorinated pesticides and all of their byproducts. Now, the most famous chlorinated pesticide is DDT, and it's been banned here since the 1980s. 2 important points. One, it's still widely used, particularly in Asia, particularly in India. It's highly persistent in the environment. It lasts decades to hundreds of years. Our exposure is primarily from the diet, and it affects the nervous system, as we well know. There are also the brominated flame retardants, the BFRs. The most common brominated flame retardant is polybromobisphenol bromodiphenyl ether, PBDE. Now, the PBDEs are added to plastics and foam products to make them difficult to burn. They are currently still in use. They're persistent in the environment. The exposure is primarily from diet or contaminated air, or actually touching or rubbing carpet and fabrics. And they too are highly toxic. Finally, the polychlorinated biphenyls, or PCBs, they're used widely as coolants and lubricants. They've been banned since 1979 in the US. They are not banned throughout Europe and Asia. Excuse me, they are now banned in Europe, not throughout Asia. They too are persistent in the environment. Exposure, again, primarily from diet or contaminated air. I can tell you that all the exposure here, when I say diet, it's not only what you eat, but it's also what you drink, what you swim in, and also what you put on your skin. So we have shown the following. We have looked at pollutants in the blood of our ALS patient and how it associates with ALS risk. Now, here's a cohort of 167 patients compared to 99 age and sex matched healthy controls. And you can see that if you look at, for example, the risk of the PBDEs, which again are the bromated flame retardants, single pollutants increase your ALS risk if you have them in your blood up to, say, 2 or 3-fold. The same with the PCBs, about 2-fold. The pesticides are by far our greatest risk, we believe, and increase ALS risk singly and as an aggregate group, the greatest. However, what we have discovered is you as a person are not just subjected to one pollutant, but when you're subjected to pollutants, you're subjected to pollutants as a family. So we devised what is known as an environmental risk score, or an ERS, which is now being more widely used. And the ERS ratio or risk of our patients increases ALS, an ERS score, a high ERS score, increase ALS risk by 7-fold. So this aggregated environmental risk is real, and it clearly correlates with ALS risk. This particular piece of data received a great deal of publicity, which we felt was good, because we want people to understand that the environment can play a role in ALS, and we also believe other neurodegenerative diseases. Now, does exposure to these persistent organic pollutants influence survival? I've shown you it influences ALS risk. So we took a completely different cohort of patients. We calculated their environmental risk score, and then we divided the environmental risk score into quartiles, with the lowest environmental risk score being quartile 1, and the highest environmental risk score being quartile 4. And what I can tell you is your hazard ratio for death is 2-fold higher in the highest environmental risk score. So the more pollutants you've been subjected to compared to the lowest environmental risk score. And this is shown here. The lowest exposure is in red. The highest exposure is in this light yellow color. And the difference in survival is 0.6 years in our cases. And this is a separate cohort. Again, this caused some, I would say both concern and publicity when we published these data. And again, we were happy about that because we want to raise public awareness. Indeed, we've called for environmental action. We are currently trying to make ALS a reportable disease in the state of Michigan, and we're at the Michigan state governmental level, so fingers crossed, as we voice the need for ALS environmental research and our understanding of this very important intersection. Because we do believe that if we can make ALS, if we can understand the ALS expososome, we can then cause, and the environmental intersection, maybe we can make part of ALS a preventable disease. So in summary, what have we talked about today? Well, our hunt for candidate ALS therapeutics. I hope you have an understanding now of what antisense oligonucleotide therapy and also the microRNA therapy is. So both the ASOs and gene therapy. We've talked about small molecules and peptide candidates and antibody candidates and cell therapies. And I've also tried to end with, can we begin to think of ALS in terms of prevention? So none of these therapies have really worked. I hope they will. But as we're trying to cure the disease, we also need to try to prevent the disease. I'm very pleased to say that we just received an NIH Director's Transformative Grant. I called it a moonshot when I wrote the grant, with the goal of making a percentage of ALS preventable in our research to try to understand why a high environmental risk score actually causes disease and increases disease progression and decreases survival. I get to come here and talk to you, but there are a lot of people back in the lab there who are actively working. And here is my laboratory. I'd like to particularly call out Dr. Stephen Goutman and Dr. Ben Murdoch, and also Dr. Stephanie Aid, but particularly Drs. Goutman and Murdoch, who have done a great deal of the work that I've shared with you today. I'd like to thank all the individual funding agencies that have helped me be here today to speak with you. Dr. Rosenbaum, who I've known for a long time, thank you for inviting me. And I thanked Sergio in the beginning, and I'd like to end by thanking him again. I've dealt with many chief residents, and never have I dealt with such an affable, friendly chief resident as Sergio. So really, Sergio, I hope I get to meet you at the American Academy of Neurology. Thank you for all you've done. So I'm very happy to take any questions, and I'll stop sharing my screen.
Thank you, Dr. Feldman. That was a very, very really nice lecture. So we open the microphone to all the participants if there's any questions.
Let's see. You know what? I hid my screen, so now I have to find it again on Zoom. Can you stop sharing for me?
Let me, yeah, I can do it.
I think you can, right?
Yes.
Can I ask a question?
Yeah, please.
First of all, thank you so much for this wonderful lecture. I really enjoyed and I learned a lot. When you were mentioning MHC, like lack of MHC on the ALS cells, I was wondering if there's any treatment targeting that, like to basically, because you earlier showed us the gene therapies. Is there any treatment targeting MHC for ALS cells, basically to express MHC so they're no longer target to NK cells?
You know what? Excuse me. I apologize. I was having trouble hearing you, so I put on my headphones. Could you repeat your question just briefly?
Sure. So when you were talking about MHC and the ALS cells lacking MHC expression,
Yes, yes.
I was wondering if there's any treatment like targeting that to let basically.
Yeah, no, that's a great question, and so the only treatment currently that's targeting it, and the reason I didn't spend more time discussing it is the treatment that's targeting NK cells. So there's a drug known as tocilizumab that actually is currently actively being used by Pfizer for other disorders. That has never been, so it's a drug repurposing program that that's independent of the drug company, but where this drug that actively targets NK cells, because NK cells are involved in many rheumatologic disorders, this drug actively targets NK cells. And so the idea is to repurpose this drug so that the MHC, so that the motor neurons will not be attacked by the NK cells. But this is simply an idea now that's in mice. But one of the other general topics that I didn't discuss in great detail was the repurposing of already approved phase 3 FDA drugs, which is also occurring very actively in the ALS field. So the answer is yes, and the target is NK cells.
Thank you.
Hi, Dr. Feldman. This is Dr. Tony Wah. I'm a stroke neurologist and interventionist. Thank you again for coming and giving us this great talk and fascinating and really exciting research. Really appreciate that.
Thank you.
I have two questions. The first one is, what's the penetrance that for those mutations used in the preclinical trials for antisense oligonucleotides? In other words, how do we convince the participants to join the trial if we don't have 100% penetrance?
Right. Okay. So that's a very good question. What they're currently doing is there are registries of familial ALS for both C9 and SOD1 for FOS, for ataxin. I think you probably know this. And so what we're doing is when a patient is diagnosed with ALS, with a familial form of ALS, now everyone is getting genetic testing in clinics. That's now free, which is wonderful. We're then seeing if an individual would want to have their family members tested. Those individuals are entering registries, and then those individuals are being offered the opportunity to enter these clinical trials. This has only really come about in the last handful of years, as you probably know. Now that genetic testing is currently offered at no cost in all ALS clinics. So that's been the turning point, because previously that was a barrier to not really know the percentage of individuals who truly had familial ALS.
So they are willing to take the risk, even they may not develop ALS symptoms.
Well, if they have the mutation. So for example, the firmest example I can give you is the SOD1 trial.
Right.
So the SOD1 trial, phase 1, phase 2, and phase 3 were done on patients with SOD1 mutations who had active disease. So they clearly had symptoms. So while that antisense oligonucleotide decreased protein expression in the spinal cord and also decreased neurofilament levels, which is a marker of disease progression, it had no effect on the clinical outcome of the patients. Ergo, the idea is to try it again on patients prior to developing disease. So particularly for the SOD1 mutation, in a way much more than the C9, depending on the specific mutation you have in the gene, you have an idea of when you usually will get symptoms. So say you've got one of the genes that you usually get symptoms at the age of 40, then the idea is to enter those individuals at the age of 35. For example, it's very interesting because for the first time, a pharmaceutical company has made a commitment to do a 2-year trial in ALS, and that's a first, to actually give drug to a patient for 2 years.
Very exciting. Also, I think that kind of takes the lead in terms of addressing these neurodegenerative disorders, the challenges we face, just like for Alzheimer's, others that they're too late in the process.
Exactly.
We're trying to treat them preclinically.
Mm-hmm. You're exactly right. That's exactly right. And I think that's part of the problem with everything we do in ALS. Yes. I mean, we have to, so we also advocate, I mean, that's one of the reasons we've developed a polygenic risk score that I didn't tell you about today, where we can fairly accurately show someone's susceptibility. Oh, I wonder what happened there. Is that Great. Me? That's George's screen, whoever George is. George is.
To fit story.
That's kind of
Thank
cool.
you. Thank you for that answer. I have another question, if I may ask.
Okay, so, it's up to Sergio. He's in charge. I'm here to answer.
Sergio, do we have time for another question?
Hello.
Yes, we can.
Okay.
Yes, great. So my second question is for the stem cell therapy and also for potentially gene therapy targeted, spinal cord injections. I presume those surgeries were done posterior approach. How do we
Yes.
ensure the targeted cells delivery and also the gene therapy products reaches the intended target, presumably is anterior horn cells?
Yes, exactly. So in order to do those, I have a whole talk, needless to say, on our FDA phase 1 and phase 2 trials. We developed a technique where we labeled the human stem cells with essentially a ferrous dye, a ferritin type compound, so we could follow them with MRI. So we did that in one set of large animal experiments. It was with mini pigs. We did 109 surgeries on 109 mini pigs. And then we had to show safety, that we could inject in the spinal cord and actually safely inject, because that was something we weren't sure of. And then we also then did the biology and showed that what these stem cells do, and then this is done more on preclinical rat and mouse models, rather than now on the mini pig, which aren't so many, these things are huge. We're able to safely inject, show that the stem cells primarily stayed at the site of injections. We're able to do both cervical and lumbar injections. In man, we did 20 cervical and 20 lumbar injections. So we did a total of 40 injections safely in patients. What we're able to show in preclinical models is those stem cells, they don't replace neurons. That's really important for people to know. What they do is they go around and it's quite interesting. They actually act as nurse cells to a certain extent. They surround the sick motor neurons, form synaptic contacts, and essentially cause the motor neurons to have a much longer survival. And they're also very anti-inflammatory and clean up what looks like a dirty inflammatory environment in preclinical ALS animal models. The unfortunate thing is that the company who provided the funding for the first 2 trials was unable to sustain financially during COVID and closed. And so there has not yet been a phase 3 trial.
Fascinating. Thank you so much.
Thank you for the questions. They're excellent.
There's a strong association with frontotemporal dementia in a minority of ALS patients. Have similar therapeutic trials been done in those patients? I mean, they're very different clinically, and they're different neurons. To me, it's one of the most fascinating things that I've come across.
Yeah, I agree with you. So let me tell you what we know now. And I would say this is when I first started, again, 20 some years ago, the dogma was that ALS patients had no cognitive decline. And so now we know that if you look at that ALS is really a spectrum, and 15% of patients have clear ALS frontal temporal dementia, no doubt. Where the frontal temporal dementia is the primary component of the disease. And for those residents on the call, what that is you really do get frontal temporal atrophy and really significant dementia in those individuals. And the ALS component of it is mild to moderate. But importantly, another 35% of patients get cognitive decline. And so they clearly are not normal. They develop behavioral problems. They have a lot of trouble in executive function. They have suicidal ideation. We now know that patients with ALS also share some of the polygenic risk with patients with Huntington's disease and schizophrenia. So half of all patients, 15% with clear FTD, another 35 to 40% with clear cognitive decline, experience these cognitive behavioral issues in ALS. None of the trials that I've discussed have tackled that. All of those trials have not openly discussed it. Those patients, though, with clear FTD are almost always excluded from trials. But it's important to understand cognitive decline early on in the disease because it affects decisions that the patient makes and the family makes. So it's a fascinating disease. the most fascinating piece, this is too long of an answer, and I apologize, you shouldn't give long answers, but if you have someone with a C9 mutation, they can either have only FTD, frontal temporal dementia, or only ALS. Same mutation. Go figure, huh?
Thank you.
Very interesting. Are there any other questions? There's things in the chat, but I can't see. I'm not looking at the chat. If there's anything that.
Yeah, there's no question in the chat so far.
Okay, good.
Oh, yes, I think there is one. Yeah, actually, in line to you. Yeah, so any identifiable early infection exposure factors?
I don't think I understood you, Sergio. I'm having my audio on. I'm glad you can hear me better than I can hear you. Let me look at the chat.
Yes,
And
basically,
say,
yeah.
oh, any
like,
identified. Oh,
yeah.
well, that's a great question, right?
Yeah.
So that's a really great question. And it's been a question that's been in the field for quite a long time. We have not ourselves pursued this. There are very good laboratories, particularly on the East Coast, who believe that there could be early identifiable, particularly viral infections that predispose one to the disease. But it's not our area of research. We have looked at predisposing head trauma and found that predisposes. And I think we also, and I did not discuss it, has several papers on occupation and another one in review where we can see that specific occupations predisposed to ALS. Serving in the military is a very high, particularly in certain branches of the military that are exposed to airplane fumes, for example, and gases. Being a production worker, so working on the line in any production occupation also clearly predisposes you to ALS. Okay.
I think that's all the questions, Dr. Feldman.
Okay, well, thank you so much for having me again. I've really enjoyed it a great deal. I hope you guys are in good weather. I never know. New York seems to be so different these days. I was born in the Bronx, so I'll let you know that.
Okay.
Okay,
should come
thank you
back
so
someday.
much. Yes, I really enjoyed it a great deal. Thank you for having me.
Thank you so
Bye-bye.
much, Dr. Feldman.
Bye.
Thank you to all the participants as well.